Okay, well, why don't we get started? Welcome to Medical Grand Rounds. And with the latest extension of the Safe at Home ruling, we are likely to continue our WebEx Grand Rounds for the foreseeable future, at least until late spring. So thank you for all connecting and being here with us virtually. Today we have a very special Grand Rounds. Pairing of two of our experts in palliative care, and very appropriate for this our current environment. And to introduce them, it's Ruth O'Regan, who is the Division Chief of Hemonc. So, Ruth?
Thanks, Lynn. Good morning, everybody. My pleasure to introduce Toby and Bill. So, Toby Campbell is an Associate Professor of Medicine, soon to be Professor of Medicine. He's in our Thoracic Medical Oncology Department in the Division of Hematology, Oncology and Palliative Care. He's also Chief of our Palliative Care Program. He has the Alan and Peter O. Johnson Chair in Palliative Care. He completed his undergrad and medical degrees at University of Virginia. We actually apparently served as the mascot for the school. I would like to hear more about that. His internal medicine residency was completed at University of Wisconsin, and then he did fellowships in medical oncology and palliative care at Northwestern University, where he also received a master's degree in clinical research. He ran the Hospice Palliative Care Fellowship from 2010 to 2017, and during that time really developed the program into a national program of excellence. The Palliative Care Program, under his leadership, has won a citation of honour from the American Hospital Association's Circle of Life program in 2017 for its innovative palliative care, and also the Patient and Family Centre Care Award from the Society of Clinical Care in 2019. His research interests really focus on patient communication and high-risk shared decision-making, empathy, models of care for palliative care implementation. His work really crosses a variety of disciplines and departments at UW, and he's published more than 35 publications in high-impact journals such as JAMA, Annals of Surgery, to name just a few. He's won numerous awards, both related to his research and his compassionate care. For research, he received the prestigious Sojourn Scholar Leadership Award from the Cambia Foundation in 2014, and Young Investigator Awards from both the American Society of Clinical Oncology and the International Association for the Study of Lung Cancer. He's received multiple awards for his clinical care as well, and he's currently a designated fellow in the American Association of Hospice and Palliative Care. Dr. Ehlenbach is from Wisconsin. He's a graduate of the University of Wisconsin School of Medicine and Public Health. He did his residency and was chief resident of internal medicine at the University of Wisconsin. He then moved to Seattle for a fellowship in pulmonary and critical care medicine at the University of Washington. At that time, he also completed a master's degree in epidemiology and also an advanced fellowship in health services research and development at the VA prior to joining the faculty here. His research is focused on, very important for the topic today, outcomes from CPR, long-term outcomes from critical illness among older adults, and palliative care in the ICU, all very important for what's going on right now. He serves as vice chair of the University of Wisconsin Hospital's Ethics Committee. He's author of more than 32 publications. So what I found out from talking to the two of them last night, I was asking them what they were doing during the COVID period. It turns out they both are very good bread bakers, and I saw that because I saw pictures of them. It was very impressive. And the other thing that we learned is that, and you may notice this today, Toby actually has taken on cutting his own hair. And I must say, it's not a bad job, I think, for his first job. So I think, Toby, you're going to start, correct?
Yes.
Thank you both for doing this. Thank you.
Thank you.
Thank you, Dr. O'Regan and Dr. Schnapp. So I am sharing my screen. There it goes. So Dr. Ehlenbach and I are going to touch on aspects of palliative care, whether that means clinical care or, as you will see, decision-making and bioethics. We're going to cross a number of domains. This is something that we put together fairly quickly in response to, obviously, the current pandemic crisis that's going on. All the photo credits that you will see through my portion of the talk are of a controlled burn in the Arboretum. And the photo credits, as you can see, are at go.wisc.edu, which, by the way, if you're looking for photos for presentations, is a great source of some really high quality photos that you can easily put into your presentations. Disclosures, I have no financial disclosures related to this presentation. I am a fellowship trained thoracic medical oncologist as well as palliative care physician, and I want to be honest with you that I find I cannot effectively practice both oncology and palliative care simultaneously with my patients. I think this shows up most clearly for me when talking about subjects like this, because it's important for me to distinguish, at least in my own mind, what hat am I wearing when I come to the bedside? Am I an oncologist? Am I a palliative care clinician? And for you all, are you a critical care doctor or a palliative care physician? Or with what kind of energy do you bring to the bedside? Our ability to measure the impact of communication interventions is limited. The truth is I don't know all the answers, but I will do the best that I can to tell you how I approach things and why I approach them in the way that I do, so that you can find your own path through and understand where I'm coming from. My communication design work tries to bridge between what I've learned from palliative care and other disciplines. And for me, it's always done in a pragmatic way, in a way in which it tries to add value and be helpful. I wanted to just take a moment to remember my friend Beth. I don't have the words to talk about this, but it's just important to me that that we spend a minute remembering her. I think she was so good at gratitude, and Mariah Quinn's Grand Rounds last week was really an excellent tour de force for Grand Rounds. And she helped me remember that gratitude is an important way of coping. And so I wanted to express my gratitude for my friend Beth, who was really nice. I'm not a great runner, but she always invited me to run around the Arboretum, which she did. I think every time I ever ran around the Arboretum, I saw her running around the Arboretum. So from my perspective, she was just always running around the Arboretum. Here's the flow for my talk. I'm going to talk about webside manner in telehealth visits, should you find yourself doing more telehealth. I'm going to touch on advanced care planning, COVID-specific advanced care planning, and what we are doing here at UW Health, as well as some available resources to you, should you choose to take some of this on yourself. I'm going to cover a research instrument that, together with colleagues, we designed called the best case, worst case framework. We rapidly created a COVID-specific best case, worst case framework and have been using it in our ICU. And it has been disseminating across the country to other critical care environments. And then finally, after Dr. Ehlenbach's presentation, we will come back and talk about some language that you might use to talk to patients and families if we find ourselves in a resource-constrained situation. So let's talk on website manner. There are some things that you want to do to get ready for your telehealth visit. Here's the overall flow. We're going to talk about the setting, about how you prepare, things to consider during the visit. What about the physical exam, how to close the visit, and then some subtle nuances that you want to consider. And I want to thank a couple of colleagues, Mihir Kamdar and Angad Singh at MGH and University of Washington, respectively, for content that they shared with me for this portion. Setting. So as best you can, you want to think about this as a clinic visit. In a clinic visit, you walk into the room and you and the patient are there, and as much as you can mirror those circumstances, you want to try to create that. So you want to do it in some kind of office-like setting. I have worked to rearrange my office. I moved a picture over behind me so that the background appears professional. I cleaned up my desk, which is not normally so uncovered with papers. You want to think about any HIPAA concerns. Are you in a shared office? Are you at home? And there might be ears who are not HIPAA compliant or not ready to hear HIPAA compliant information. So can you protect privacy in important ways? Are your devices charged up or plugged in? Do you know the software that you're using? And do you have some basic patient-side troubleshooting skills at your disposal? I have been doing telehealth visits as part of research for probably a little over 2 years now. And I can tell you that even patients who have repeatedly met with me in a telehealth platform, many of them, particularly lung cancer patients, because often they are, in their 60s, 70s, and 80s, they need help every time we get together. Even though they've done it 5 times before, they need help that time too. And so you just have to be ready for that. Also, you want to have a phone backup ready. So sometimes the video will come through, but you'll have problems with audio, and you can connect with them over the phone while still having a video connection. And sometimes the whole thing just doesn't work, and you need to resort to the phone. So be ready, have a phone handy for a backup plan. All right, so once your setting is organized, you want to prep a little bit. So where's the camera? How far away from the camera am I? I mean, you know, there's these awkward things where you're just really too close, or you get like these terrible shots up your nose if your camera's in the wrong place. So the ideal position for your camera is somewhere around forehead height. You want the camera, if possible, looking down on you a little bit. You might want to, if you're using a laptop, perhaps you place it on an elevated position. You'll get a much more professional view of yourself if the camera is a little bit higher. You want to think about your distance from the camera. Most conversations are done at arm's length, so you want to be roughly at arm's length from the camera. Think about your posture. This is not, you know, time to, you wouldn't do this in a clinic visit, and you don't want to do it on a telehealth platform either. So you want to think about your posture and how you're sitting. And then really, there's just a fundamental mindset. This is a visit. It's not a phone call. Schedule it on your calendar. Try to run on time, or at least as on time as your regular clinic runs. I've been doing telehealth visits these last couple of weeks, and my clinic runs about as efficiently as it normally does, which is to say I run a little bit late, but I'm consistent. Okay, let's think about how you set this up. Thanks to my creative and inspiring colleague, Amy Zielinski, who sent me a picture yesterday of what happened to her at a telehealth or in a video chat visit. You want to think about this. So I've got my screen. I want my camera. Really what's the most helpful, because it helps to mimic eye contact the most, is to minimize the patient's image and scoot it up next to your camera. So what that means is that the screen is not full of the patient, but actually the patient's video image that's coming to me is pretty small, and it's right up next to the camera, so that as I am looking at the picture of my patient or the video of my patient, it appears to them that I'm making eye contact through the camera. So this is the optimized place to place the video. What this also allows you to do is bring up some, for example, you can bring up HealthLink notes as a floating window. You can bring it up, of course, on the side or on the bottom, wherever it fits on your screen. I usually have it as a long text box along the side, which allows me to most effectively see my note as I'm typing. You also can, depending upon how much landscape you have on your screen, you can often have HealthLink open as well, which I find particularly helpful. Just like in a real clinic visit, if I'm typing or if I'm referencing the chart, I tell the patient what I'm doing. I think in a video visit, it's even more important because patients don't know, what you're doing. They can probably hear the typing. And so I usually disclose to them, I'm going to be typing and taking notes as you're talking, just so that I can remember what you told me. If I'm looking up something, if a question has emerged, like what did my CAT scan show or something, I can say, well, actually, I have your health record up. I'm going to look at your CAT scans now. So this is what I think is an optimized setup for your screen positioning of things. Now, during the visit. Okay, so telehealth visits are a little awkward, right? So what can you do to minimize some of that awkwardness? Well, one thing is actually to smile. As you're opening the visit, smile, good morning, and wave. While it feels kind of silly, it actually makes a big difference in terms of establishing rapport and helping to get some of those technological hurdles to the human connection out of your way. I also find that naming the awkwardness is important. So I'll smile, I'll wave, I'll say, this is a little bit strange that we're meeting over the computer here. I sure look forward to the days where I can see you in person again, or something like that. And finally, I give my patients permission to let me know if they're having tech issues or other issues that I can try to help them solve. Make sure, Sally, that you let me know if you're having any trouble seeing me or hearing me. I want to know about that so we can have a good connection. And they have permission now to let me know if there are issues that emerge. How about some nuances? So some things are easy to misinterpret over telehealth. So silence is tricky. In a normal clinical visit, you might use more silence, but on a telehealth visit, it sometimes they can think that maybe your screen froze. And so you have to do things like increase your nonverbals, because for example, leaning in, or sometimes leaning in with a hand on the chin to show that you're listening. You have to be careful and actually avoid little uh-huhs and yeses, because actually the mic will pick you up And as you all have been experiencing in your video chats over the last month, there's this awkward, like, who's talking? Are you talking or am I talking? And so actually when the patient's talking, you want to use more nonverbals, like sort of exaggerated nods so that they can see you, or leaning in gestures, but actually minimize or even avoid altogether the little verbal utterances that we typically do in human speech that actually don't work well on a telehealth platform. What about the physical exam? Well, it's surprising how much you can see with the camera if you direct them to how you want them to hold the camera so that you can see what you want to see. Obviously, you can't do a cardiac exam, but there are many things that you can see with a camera that allow you to do a fairly significant portion of your physical exam. But maybe it's not enough. Well, I just want to free you to say, you need to direct them to come in for a visit. If you feel as though you need to physically examine the patient in a way you can't do over telehealth, it's important to realize that patient care comes first. And if they need to come in, they need to come in. What about closing the visit? One of the things that I find helpful about staying on time is just signaling. I see that we have about 10 minutes left. I want to make sure we've covered all the things that were on your list. Closing with a summary of the visit to make sure that our takeaways are shared. So the things that I'm taking away from this visit are that you are having shortness of breath and a cough. I've sent a prescription to your pharmacy. I've got a plan to do a CAT scan sometime in the next week, and then you and I will connect again over telehealth, whatever the summary is. And finally, wave goodbye. Makes a big difference. Troubleshooting, a couple things that I've learned over the years. The audio is out, but the video is working. Call them on the phone and keep going with the video. What about interpreter services? Call interpreter services on the telephone. So for this, you want to use the telephone, not the video. So you call interpreter services on the telephone just like you would normally if you're using a telephonic interpreter services. So they're going to three-way with you and the patient. All the audio is going to be on the phone. Here, just remember to look at the patient. You're talking to the patient. The interpreter will provide that audio, but you're always going to maintain eye contact with the patient at all times, which, by the way, is how to work with an interpreter in person as well. So let me transition to thinking about planning. So just because we are facing a pandemic, an unpredictable event, a crisis, even though this is unpredictable, it's not something that we can't anticipate and we can't plan for. All of us have spent a lot of our time planning. I'm sure many of you have spent a lot of time planning for different contingencies as well. One of the ways I think in which we can help patients plan and prepare is through advanced care planning. So why might we do this? Well, communicating with patients about serious illness is hard. It's hard under the best of circumstances, and this is not the best of circumstances. This pandemic really, in my opinion, reinforces the need to let patients with serious illness express their values, their worries, their priorities, their hopes, their goals, and give them a platform to make an informed decision in advance of a crisis. We don't know who exactly is going to become affected by the virus, but we do know that some people will. So we can plan for this. Who should we approach about doing advanced care planning? I think primarily about patients who are at home, who have underlying health conditions that place them at an increased risk of having critical illness or even death if they were to develop COVID-19. When? Well, we can do this anytime, really. We are doing this via a telephone call that's scheduled at a time when the patient and a family member, or ideally a decision maker, can be present. This is helpful for more than just the patient to hear. As the patients are expressing their values and hopes and goals, it's handy. In fact, I would argue crucial for others to hear that conversation. How might you go about doing this? So I think it actually works quite well to set this up over the phone, either by you or your staff. I also think a MyChart works. I have used MyChart for this purpose and found that I haven't had anybody really push back. So the script goes a little something like this. I'm calling to see how everyone is doing. It is a difficult and scary time. I imagine you're worried about your health right now. Because of your underlying lung cancer, I'm also worried about what might happen if you were to catch this COVID-19 virus. I'm committed to providing you with the best care possible. Would it be okay for me to connect you with a facilitator, someone who will call you to talk about what's important to you and explore further your healthcare wishes and preferences? Almost all of my patients have admitted that they were already worried and scared. Almost all of them, after going through this process, have come back to me to say they felt better having explored it. They felt less scared because they'd had a chance to talk about it. There are going to be different processes, perhaps at a local level. For example, I know geriatrics is going to be doing their own process, and bone marrow transplant is doing their own process. But as a general process, our absolutely amazing Cassie Shumway, our RN nurse coordinator for the palliative care, our clinical program coordinator for palliative care, is taking in baskets, and then we are triaging things to different places on the backside. We are using here at UW the Respecting Choices framework. I've got a link for you in the slides if you you can click on that and see their resources. We use Respecting Choices in general for our advanced care planning resources here at UW Health. It is the framework for which the state of Wisconsin adopted what they are calling honoring choices. So it's a framework that statewide we are familiar with. There are other resources though. Ariadne Labs, which is an organization at the Harvard Chan School of Public Health, and I have great respect for the researchers and the staff at Ariadne. They have recently put out a conversation guide in a variety of circumstances. They've got an inpatient conversation guide, an outpatient conversation guide. They also have an advanced care planning conversation guide. So if you want to be conducting these conversations yourself, I would suggest that a great way to think through what the conversation might look like and how it might unfold is to start by looking at some of these conversation guides. Here on the screen, you can see their inpatient care guide, and I'll just point out, you know, they have the setup, assessing the situation. So they're giving you the qualitative categorical types of questions, not that you would necessarily use all of these questions or necessarily in this order. They're giving you options. I'll zoom in a little bit. So setting up this conversation, this is again an inpatient conversation. This is a difficult and scary time with the coronavirus. I'm hoping we can talk about the upcoming hours and days and what's important to you, that we can provide you with the best care. Is that okay? Just good questions. And so here again is the link to the Ariadne Lab resources where they have among them these conversation guides. They also have a patient preparation guide, which allows patients to get ready for an advanced care planning conversation. It asks them some questions and gives them some things to think through in advance. Oftentimes, perspective matters a great deal to how we process and cope with something serious. Here you see someone walking down a fire line, starting a fire. And the situation can look wildly out of control if you're right up close to it. But if you take a step back, you might realize that actually this is an orderly process in a way. The lines are clear, they were planned in advance. And the fire, while itself a dangerous problem, has been set up in a way to try and create some safeguards and some safety. Together with my indomitable colleague, Gretchen Shorzy, and the creative and always inspiring Amy Zielinski, as well as a number of residents and fellows over the years, we have developed a series of communication tools under our best case, worst case umbrella. We rapidly developed a COVID-19 approach for communicating with family members who are kept at a distance from their loved ones in the ICU. So we initially envisioned critically ill patients who are unable to communicate because they were on a ventilator and families who are at a distance. Although we also, in response to requests from hospital medicine, designed a separate approach for patients who would be awake, hospitalized, but also kept at a distance from their family members. And so I'm going to go through the resource that we created here fairly quickly, although I've given you a link. You can download all of these resources for free. You just have to register so that we know who is gaining access, but they're free and available for use. We've heard from ICUs across the country, actually, who have picked this up and are starting to use it. So at a baseline, it just looks like this. It's a piece of paper. At the top, best case and worst case for a COVID-19 infection in the ICU. On the top, we have our the date, as well as any events that happen. So for example, this might include, you know, kidneys are failing or had to be placed on a ventilator. So we usually record big events of the day. There's these vertical lines, and along the vertical lines, we place a star representing the best case outcome that we're hoping for. Underlying this, there's a lot of science underlying how we've designed these best case, worst case tools, but we use what we call scenario planning, which is essentially translating your knowledge of outcomes and statistics and medical events into a story that a patient and family can easily understand to help them get perspective around what's possible, around what might happen. The best case and the worst case are, if you think about like a 95% confidence interval around an event. Let's take someone's health, for example. You, as a clinician, an expert clinician, have an estimate of what you think is most likely, what you think might happen to this patient. But you recognize that there's uncertainty. Best case, worst case helps you take into account uncertainty. And the way it does that is creating some 95% confidence intervals. Here's how bad it could go. Here's how good it could go if everything went our way. Here's maybe what I think is most likely. So that's really what the whole thing is. With the addition of this pen and paper diagram, it turns out that the pen and paper diagram takes a few minutes extra, but makes all the difference in the world in terms of what patients and families tell us about how well they're able to remember your conversation, about sharing it with other family members who are, again, spread at some distance. And so this pen and paper diagram turns out to really pull this whole thing together, and it turns from just using the words best case and worst case, which I'm sure everyone uses, into a communication tool and a framework, and what we would call a designed conversation. I'm going to show you some examples in a minute. Over here, though, you can see we've pre-formatted the worst case because really it's quite stable across all of these patients. And it's critical care in the ICU that lasts for days or weeks, that over time they get sicker, need even more treatments and support, and that they could even die from this infection. So let me just go, just to help make this clear, I'll show you some examples. Here's a patient who over time you can see is getting worse. You can see that the stars are going down, and you can, along the top, you can see that there are some events. So on 325, the patient needed oxygen. And the best case scenario that we were hoping for at that time, when you're talking with the family, might have said it something like this. You know, we're hoping that this oxygen will help his breathing enough so that he can avoid having to go to the ICU. I suspect that he'll need to be in the hospital for at least 1 or 2 weeks as we see how things go with this COVID-19 infection. One of the things that we follow is something called CRP, and when it's low, that's a good sign. Usually less than 40 is good. Right now, his is less than 40. So based on what I know about him, because of his underlying COPD, I am worried about him. And I think that what's most likely is probably that we're heading towards the ICU, unfortunately. The trajectory over the last few days makes me think that that might be where we're heading. So then you can see as 326, there were no major events. On 327, his CRP is rising and he's needing more oxygen. You can see that the clinician is placing the star in a lower position. And then you see the patient has a period of stability over the next few days. Now, I'm going to show you what we do with these documents, but typically they are placed on the door outside the patient's room. And this allows all members of the clinical team to rapidly develop a few things. One, an understanding of what the patient and family have been told. So that when you talk to the family, if you have an offline communication with them, you will have a pretty good idea of what they've heard. That allows you to organize the way in which you express the news that you're delivering to them within that construct and within the confines of what they've already been told. So for example, we have lots of euphemisms, right? So acute renal insufficiency, someone else might say kidney failure, someone else might use a different set of words that to us might mean the same thing. If you know that the family had been told that they had acute kidney insufficiency and you thought those words fit the situation, you could use those same words. That would avoid confusion. It allows the teams to pretty quickly get that 10,000-foot viewpoint. So at times of transition, what we've heard from the ICU teams is that the document really helps them get a big landscape view of how the patient's been doing. And then finally, it allows different teams to get on the same page. So as a consultant coming by to see a patient, I have a pretty good idea about how the ICU is thinking about this patient and what they've told the patient's family. So that's an example of a patient getting worse. I've got an example in here, though, of a patient improving. You can see the CRP is going down. They're needing less oxygen. They're off the ventilator. We've got, here's a patient who's doing quite terribly and actually transitions to end-of-life care and dies. On the back side of this paper, posted separately, we try to capture some of the things that the patient enjoys. In this case, Steve enjoys gardening, plays euchre weekly with his friends, grandchildren, and classic cars. You would be amazed at the feedback that we get from team members, from critical care team members, about how helpful this is to bring the patient to the bedside, to have some sense of who they are. This also helps you with your communication. So if you want to talk about the best case for Steve, then you need to incorporate gardening and being able to leave the house and go play euchre. So he needs to be cognitively intact, at least well enough to play euchre. He needs to be able to be physically intact, at least enough to be out and gardening. And so those key elements, patients' values and goals, can show up in the way in which you talk about how they're doing. So for example, you might say, things are going, this is rough. And it's hard for me to imagine Steve being able to garden this summer, because I think he's going to need to be in the hospital for a long time in the nursing home. So you can imagine just incorporating seamlessly gardening into the way in which you talk about it. Here are a couple of real examples. I realize the resolution is low, and that's okay. I just want you to see what this looks like. This is an actual document on the actual bedside of a patient. We've blacked out the name. If you look, you can see the black stars. You can see this is a patient who has relative stability. The stars are kind of holding in about the same place. Towards the end, they rise a little bit. I'll zoom in on, so there you can see the stars a little bit. And then here's the actual picture. So this particular patient, the things that were important were gardening and making syrup from his trees. His family wanted us to know that he knows everyone in town and they know him. And that he's the oldest of 12 siblings. And so this is a real document from the bedside of one of our COVID positive patients in our ICU. And I think you can see that that helps you get a sense of who this patient is. Sometimes, though, perspective doesn't matter. We are in a crisis situation, and it is the case that the fire is burning out of control. And at this portion of the presentation, we're going to turn to talking about resource scarcity. And there are a couple of resources that I'm going to talk about in a bit after Dr. Ehlenbach goes through the ethics around resource scarcity. Here are a couple of links for you. The first one is a UW Health document that's been prepared for talking points with patients and families. And the other resource that I wanted to provide for you is the what's called the Vital Talk Playbook. Vital Talk is a nationwide organization that focuses on patient-doctor communication. There are a number of Vital Talk participants or faculty members who are here at this institution. I, merely because I'm older than everyone else, have been involved with Vital Talk since its very beginning. Actually, I was a subject on their original studies. But Sarah Johnson in the Division of Palliative Care is one of their faculty members who teaches for them nationally and probably internationally. Liana Escola and Jessica Baker, as well as Kate Schuler from the Division of Hematology Palliative Care and the Section of Palliative Care are Vital Talk faculty. And this playbook was developed by the Vital Talk community, really sort of crowdsourced to come up with a variety of question and answer responses for patients and families in this situation. So we'll go through that, but let me first turn to Dr. Ehlenbach.
Thank you, Toby. Let me share my slides here. So I'm going to be touching upon reality that we hope doesn't come to pass locally, but one that we know has occurred in various places around the world. Just for my disclosures, I don't have any financial disclosures. I am the co-chair of the University of Wisconsin Rapid Response Ethics Team that was formed during this pandemic, and I have been participating in the Ventilator Allocation Advisory Work Group, advising the state on the development of a triage protocol. So I want to talk about a problem that we all know could develop and has developed. And very simply, this is the problem of, as it's been put, too many patients, too few ventilators, or too few resources. And so what I have on this slide is an example of some diagrams representing individual patients shaded with their mortality risk, basically their severity of acute illness. And here we have 21 patients and only 6 ventilators. And one of my goals is to make you think about the fact that decisions in a setting like this are inevitable. There is no choice of practicing the way that we usually would, because our usual practice is predicated on having enough resources for to meet all the needs of our patients. So I want to briefly talk through some of the different ways that we might actually approach this problem of allocating those resources, those scarce resources, to the patients who need them. And again, this is a possible situation that we're talking about where the fire is out of control. The number of patients are just exceeding our capacity to care for them. So in some ways, the way we usually practice involves the notion of first come, first serve, meaning that patients who have already arrived at the hospital and have started to receive a given therapy are the only ones who get that therapy in this example. Another way that this is sometimes described as squatters' rights. In other words, the patients who, by virtue of their proximity to the hospital, perhaps by virtue of their advantaged position in society, they got to the hospital first, they're receiving the resource. Those who arrive later, in this example, all of these patients need mechanical ventilation. All of them are assumed to have a high risk of dying or a likelihood of dying if they don't receive ventilation. In this example, many of the patients who are already receiving ventilation have an exceedingly high risk of death even with ventilation. And in this example, we end up with almost all of these patients dying. We've essentially saved one or maybe two of them in all likelihood. We sometimes, as physicians, have the urge of treating the sickest patients first. And again, in our normal practice, in our normal situation of resource abundance, that is likely appropriate. But again, here, this would be an approach that would almost ensure that most or almost all of these patients die. We would be allocating ventilators to patients who are likely to die even with ventilation. And all of the patients who have some reasonable chance of surviving with a ventilator die because they don't get the ventilator. So I think it's apparent this is not the right approach in this setting. Certainly you can imagine randomly allocating the resource or even having a lottery, and there are some who have proposed this as a fair way of distributing scarce resources, though again, whether a patient who receives the ventilator is likely to benefit from it is just a matter of chance. So while this may be thought of as a fair way, it is not an effective way of distributing those scarce resources. Another possible approach would be just let physicians at the bedside figure it out. You have emergency physicians, you have critical care physicians, you have hospitalists. Let them on a one-by-one basis figure out how those limited ventilators are going to be distributed to that large group of patients. And who knows how that would go, although it is hard to imagine that approach would be fair or effective. So what I would propose, and what most have proposed as people have thought and written about pandemic triage protocols, and a lot has been written about this over the past 15 to 18 years, most would advocate a primary approach of prioritizing the patients most likely to benefit from the scarce therapy. So here, this would be a case of matching ventilators to the patients who are most likely to survive with ventilation, and thereby trying to save the most lives. I think it's important to recognize that any of these scenarios, or just thinking about this context of too many patients and too few resources, I think it's important for us to recognize that would be a tragedy, and that there would be, a high number of deaths, tragic deaths, deaths that we all, in an ideal world, would hope that we would avoid. So let me talk a little bit more about the organizing principles, and I will touch upon some that I think are widely agreed upon, and I'm going to talk about some that are the subject of quite a bit of debate and some controversy. So that notion of prioritizing the patients most likely to survive is usually described as a goal of trying to maximize the number of lives saved. And while that would look quite different in this crisis situation, I actually think that's a goal that always guides medical practice and certainly public health practice. We have a profession whose goal is to try to minimize mortality and morbidity, and that would be the underlying goal of this approach. It also acknowledges that we would be in a context in which many patients are not going to survive, regardless of the strategy used. An alternative goal, or a secondary goal in some triage protocols, would be the notion of maximizing life years saved, which would really mean thinking not only about acute risk of death or the severity of critical illness right now, but would be about thinking about the patient's overall health status. So this would be an approach where you would prioritize care to patients who do not have serious comorbid illness over those who have illnesses that limit their life expectancy. I will touch upon some of the concerns about bias in a few slides. There are also concerns about the subjectivity of the assessment. So whereas we have validated objective tools that are readily usable at the bedside to predict short-term mortality risk, I would argue that there's quite a bit more subjectivity as we try to think about longer-term risk. There's also concerns about amplifying existing disparities, and I'll touch upon that in a few slides. A third principle that underlies or is part of some of the protocols to guide decision-making in crisis triage is what's often called the fair innings argument. So basically stating that in a fair world, everyone would be entitled to some normal span of life years. In this thinking, a person who has not lived through major life stages or has had the opportunity to develop fully through childhood, to experience an education, to get married if that's a goal, to raise children if that's a goal, to have a career. Somebody who has not gone through all of those stages or had the opportunity for those stages of life has not really had the fair innings and might have a priority. I would argue this is a reasonable criterion to prioritize among groups of people with similar short-term prognosis. This obviously does use age, and that certainly makes some people uncomfortable, and others really object that age should not be a criteria. I do think it's important to point out that there are other potential rationale for using age in triage decisions other than the fair innings argument, and most of those I think are bad, and certainly some people advocate giving priority to younger patients because they have a greater future social contribution. I don't think that's a compelling argument. Others would argue that older patients have likely already consumed more healthcare resources and that they should be deprioritized for future healthcare resources. I don't think that's a compelling argument. But fair innings argument is one that doesn't rely upon notions of social worth or social contribution, and I think is in many of the triage protocols that exist is a criterion that is used. So there are a number of protocols that exist, and we, the Rapid Response Ethics team at the University of Wisconsin, have developed a protocol. As I mentioned, there is a group that has been advising the state on developing a protocol. There was an article in the newspaper this very morning suggesting that the state may delay uptake of any suggestions at this point, because there is a feeling that at least now we have a bit more time to think about how this might work, since it does seem that in the state of Wisconsin, and certainly in Dane County, there is no likelihood in the short term of needing to use such crisis triage protocols. But most of the protocols that exist in various states and from various authors have a goal of maximizing life years as the primary goal, or a primary goal. Many do use age as a secondary criterion, using the fair innings argument. Some advocate maximizing life years, again, and some advocate the life years argument as kind of a secondary criterion to choose amongst groups of people with similar short-term prognoses. There is widespread agreement that there are a number of factors that should not be considered, and I, would name those as including race, disability, gender, sexual orientation, and a whole lot of others. Immigration status, incarceration status, really should not be considered by those who are making allocation decisions. Which leads us to think about, well, who would be making these decisions? Who would be implementing any protocol that exists? And I do want to touch upon that. First off, I think it's important to consider, when would you actually activate a triage protocol? The first thing I think is important to say is that healthcare organizations and healthcare providers really do have an ethical obligation to maximize capacity. I have really been impressed by the efforts of UW Health to do just that, to think about every way possible of utilizing the human resources, the space, the equipment that we have to dramatically increase the number of critically ill patients for whom we would care. And I think there is an obligation to do that. I think it's important to note that triage protocols really only should be invoked when critical care demand outstrips or is about to outstrip supply. Another way of saying that is we should not hoard resources. We should not say, well, there's some chance a few weeks from now we may reach capacity, so let's start implementing triage now. So it really should be about impending, imminent, or existing supply-demand mismatch. And a decision about invoking triage, again, is not made by individual physicians at the bedside or groups of physicians. This is a decision that really has to come from incident command. And really, that decision from incident command is not only guided by the up-to-the-minute understanding of our resources, but it's also taking in external information about what is going on around us, what is the pace, what are other hospitals facing. All of the protocols that exist, and certainly the ones that we have recommended for the University of Wisconsin, include either utilizing a triage officer or I would think, in a better case, utilizing a triage team. And those are the folks who should be making these decisions about allocating scarce resources. I don't think it would be fair to ask physicians at the bedside to play this role. And the triage team is one that should really be well-versed in the predetermined objective criteria that have been established in advance of triage needing to be invoked. Decisions and the data that guide decisions should be tracked, should be logged, should be periodically reviewed. I think it's important that this process be reviewed in an ongoing way to make sure that it's doing what we want it to do, to make sure that it is free of bias. And that's a very important part of this whole process. And as I said, the bedside team really should not be burdened with making these decisions. If we entered a triage circumstance, allocation decisions would apply to all patients. It's not just those with COVID, it's not just those without COVID. The approach would be to think about how do we maximize the number of lives saved, and thinking about severity of acute illness and risk of death, regardless of whether somebody has this infection or not. One point that I think is incredibly important is the point that withholding and withdrawing a therapy are morally equivalent. There's widespread consensus on that. There is also an understanding that they feel incredibly different. They feel different for providers, for physicians and nurses and other professionals. They feel different for families. And I think it's important to acknowledge that they feel different, while emphasizing that we think they are morally equivalent. And then allocation decisions don't just apply to new patients, right? If we entered this circumstance, we would be considering all of the patients already receiving critical care and those who newly need it in making these determinations. Just want to briefly touch upon the fact that almost all of the existing triage protocols use SOFA score as an objective, validated metric of severity of critical illness and really as a risk of mortality. I don't want to go through this in detail. There's also a score called the PELOD, P-E-L-O-D, that is widely used in triage protocols when thinking about pediatric patients. So that's a validated prediction tool for critically ill children. I think, and one of the reasons that I think, palliative care and some of the communication strategies that Toby has highlighted are so important is that if we entered triage circumstances, one of the things that would be the hardest, and frankly, I think feel the worst, is the notion that patients who are excluded from critical care, meaning as somebody who needs a ventilator but cannot receive it, or somebody who is on a ventilator and is either too sick to continue to receive that or declining, when decisions are made, their surrogates would be informed of a decision to withhold or withdraw, not asked for permission to withhold or withdraw. That is very, very different than our usual practice. But again, I think in this setting, given the principles and goals that we've discussed, that would be the right way to proceed. That would be the ethically sound way to proceed. Certainly, patients for whom critical care therapies are withheld or withdrawn should receive comfort-focused care, and certainly patients who are dying should receive symptom management at the end of life. And that would be a really important part of caring for patients in this crisis. I do want to touch just for a minute, and certainly we could talk about this a lot longer if we had more time. There are concerns about bias in triage protocols, and in particular, concerns about the way that focusing on life year maximization can disparately impact groups that are already disadvantaged or marginalized or discriminated against. So I'm just going to pull out a couple quotes. The top quote was from a disability rights activist, published in the New York Times on March 23rd. So even in a crisis, authorities should not abandon non-discrimination. By permitting clinicians to discriminate against those who require more resources, perhaps more lives would be saved, but the ranks of the survivors would look very different. Biased towards those who lacked disabilities before the pandemic, equity would have been sacrificed in the name of efficiency. And I think that's a pretty good summary of some of the criticisms of all of the triage protocols that have come from some disability rights groups. So just be aware that those controversies exist. The notion of considering comorbid illness as part of a life years maximization goal, there's also real concerns about how that disparately it would impact African Americans. And we know New York and Detroit and Milwaukee and Chicago and New Orleans, Black people are bearing a high burden of this disease, getting infected more and they're dying more. So this piece from last weekend in the New York Times, or just a couple of days ago actually, baked into the triage protocols are biases that disadvantage groups who, even without a COVID-19 infection, experience worse health because of historical and structural reasons, especially Black people. And I think it's important to be aware of these controversies. Some have identified that healthcare workers should be prioritized in triage schemes. I would tell you that what we have recommended for the University of Wisconsin and for the state of Wisconsin does not prioritize healthcare workers. There are three reasons sometimes given for prioritizing healthcare workers. The instrumental value one is one that I think can be compelling in certain circumstances. So this is the idea that if you want to save more lives, you have to keep your healthcare workers available to save those lives. I think that would be really relevant if we had an effective treatment that was limited in availability, or if we had a vaccine. I think this argument would be compelling to prioritize. If we're talking about a healthcare worker, so if I become infected with this and I have respiratory failure and a high risk of death, it is unlikely that even if I survive, I'm going to be back providing care in this pandemic, and so that feels less compelling when we're talking about ventilators. I don't think that rewarding healthcare workers for taking risk makes sense, because there's a lot of people in our society who are taking risk. I also don't think it's necessary to give healthcare workers priority to get them to show up for work. I think our colleagues are showing up to work, and we're seeing this all over the world. Healthcare workers are bravely taking care of patients, acting out of a sense of duty. Again, some have asked if pregnant women should be given priority, although most, I think, or a lot of protocols do not, but I just raised that as a potential controversy. Finally, it certainly would be nice to have time and to really get public input about triage protocols, to have vetting by diverse groups of citizens. I think that would also serve the interest of transparency. Disseminating these widely can reduce public mistrust. And I think if you look anywhere in the lay press, there is a lot of concern, there's a lot of fear, there's a lot of distrust about triage protocols and how they would work. I think any of these protocols should be viewed as a living document. More and better data should inform the protocol, and in particular as we learn more about mortality risk from COVID. So at this point, I am going to turn it back over to Toby.
So just in the final few minutes, I'm going to truncate some of these comments, but I think you all will have access to the slides, and I've given you the Vital Talk and other resources, the UW Health resources that you can look at. But I just want to come back to, there's a concern that, when you're having these intense conversations, you need to use the right words. And I don't dispute that there are some words that are more effective than others, or really more that some words can get you into trouble sometimes. But what I want to communicate is that the intent that you bring to the bedside when you're having these terrible conversations about resource constraint matters more than any singular word choice. Even when we were writing that Vital Talk document, there was a lot of rich debate among communication nerds about the phrasing and how things would unfold. And I think that should suggest to you that really well-meaning people who have studied this art are not always on the same page about how exactly they would express it. So there are no exactly right words. Those don't exist. The intent matters a great deal. So step one would be to break bad news. Because of your grandmother's underlying cancer, your situation does not meet the criteria for the ICU right now. The hospital is using special rules about the ICU because we're trying to use our resources in a way that saves the most people possible. So here, let me break this down just briefly. I'm being very clear about the factor that we were weighing in this particular case. It was this underlying cancer. I'm being very clear that her situation does not meet the criteria for the ICU, so I'm being deliberate. I'm not asking them to make a decision. I'm not placing that burden on their shoulders. I made the decision. I'm putting that outside of me. The hospital is using these special rules, so I've taken this off my shoulders and off their shoulders. And then I've stated our priority, to save as many lives as possible. Now, I want you to imagine, I think one of the things that's going to help you get into the right mindset is to imagine what the family member would be saying to their family on the phone. So Amy Zielinski can teach you that one of the most fundamental aspects of expressing empathy is being able to take the perspective of another. But it turns out that that's really hard to do. It takes practice. It takes some effort. One of the things you can do is imagine this phone call. So let me imagine that you are, I don't know, Travis, and Travis is calling his family about his grandmother. And so there's two alternatives, right? One is that Travis was asked to make a decision, and the other is that we did unilateral decision making. We informed Travis. So let me just briefly play this out. All right, so you're Travis. Hey, I just had a meeting with the doctors. The doctors were really nice, and they went through everything, and they said grandma's not likely to make it. And we have to make a choice about whether or not to take her off the breathing machine, because there are other people who need it and can't have one and have a better chance of surviving. All right, so Travis's other alternative when he's talking on the phone is to say, I just had a terrible meeting with the doctors. They were really nice about it, but grandma's not going to make it, and they're going to take her off the breathing machine, and she's going to die. Okay, so they're subtly different, but now I want you to imagine Travis at, I don't know, Thanksgiving dinner for the next 10 years, right? And so in comes Travis, and in the first hand where Travis made the decision to withdraw life support together with the doctors, you can imagine Travis walking in and, Uncle Billy saying, hey, killer, how you doing, man? Or you can imagine Cousin Frankie saying, hey, Travis, you want some sweet potatoes? Oh, that's right. Grandma brought the sweet potatoes, and you killed Grandma, so you can't have sweet potatoes. Or someone else saying, hey, there's Travis. If I'm ever in the hospital, don't let him talk to my doctors. So you put Travis in a really awkward position. It's much more advantageous to really that whole family if the decision-making for this process is shouldered. But I also want you to realize that Travis is very unlikely to not push back, right? So Travis is going to respond to this. He's going to push back, and we have to prepare for that and accept that that is a reality. So in this document that you will see from UW Health and others, you will see some of the pushback. So, are you just discriminating against her because she's old? So here, a rebuttal. No, absolutely not. We're using guidelines, and we've got some other examples of rebuttals. I'm just conscious that we are, oops, I didn't mean to do that. We are at time. And so we've got some examples of rebuttals that could help you as you face, if you were to face these difficult conversations. All right, Dr. Schnapp, or
Great. Thank you so much. That was a wonderful presentation and very appropriate. It looks like I'm going to let Ruth moderate the questions.
I think, sorry.
Maybe we'll just.
So we've a couple of questions here. So the first one is for Bill. It's basically regarding the models that we have in terms of, long-term predictive models in terms of maximizing life years. Jim Stein wants to know, how good are these models?
Yeah, so I think that's a great point, and I think that is one of the challenges, and certainly I would argue strongly against maximizing life years as a primary goal, and for the most part I would argue against using it as a prominent secondary goal, just for the reasons that Jim raises. So first off is, how good are we at actually predicting? And I would even raise, in the crisis setting, we may be taking care of patients that have never been in our hospital before. We don't have visitors allowed. How good are we at actually even assessing comorbid illness to have an accurate prediction of long-term survival? The second part of Jim's question is, and again, I think it's an exactly perfect point, is aren't all of these the things that contribute to long-term survival, aren't they confounded by things that we shouldn't consider? Sex, race, socioeconomic status, and to me, that is the most compelling argument against schemes that try to maximize life years, is that you end up amplifying the inequities, the things that have led to the social determinants of health, and you end up prioritizing already advantaged people over disadvantaged and marginalized groups. So I think that is the large criticism of schemes that maximize life years. So I think that's a great point, Jim.
And for both of you, what are the discussions about triage at a community or regional level, given differing resource availability and patient populations? Toby, you want to start that one?
Well, I think I'd be interested in your perspective too, Bill, but I think of all of our resources as community resources. I would hate to hear that because Milwaukee has more cases, that patients are dying, particularly Black patients are dying in Milwaukee, when we have capacity here at UW Health. So to me, this idea that we're all in this together means we're all in this together. and that it's important that we step up and think of our resources as regional.
Yeah, and I completely agree. And actually, I think this really highlights the potential benefit of having states involved in helping to coordinate resources. And again, I mentioned what I think is an ethical imperative for us to maximize our capacity. I would also argue that there is an ethical imperative for us to coordinate care so that we can either get the patients to places where there are excess resources or get the resources to the patients where they are. And I think that is challenging for, no health system can do that on their own. So whether there is a cooperative effort of health systems coming together, or whether you have, so the state of Washington, for an example, has a pre-existing kind of well-organized, state level group to bring all the health systems and different hospitals together to think about triage, to use a unified protocol, but also to coordinate resources. And again, I think about, we don't normally in Madison care for patients who receive care in Milwaukee, because Milwaukee's a big healthcare market with a big academic medical center. But what a tragedy it would be if there were patients dying in Milwaukee because of resource scarcity, which certainly is not happening now, to our knowledge, and hopefully never does. But if that were to happen, and there were resource scarcity there and excess resource capacity in Madison, to me, that's a tragedy that we need to do our best to avoid. That can't happen.
So another question is, wondering, Lynn, do you want to end now, or?
Yeah, I think so. We're running over, and I think there's a lot of questions. I'm sure Bill and Toby will be happy to answer them offline.
I was just going to say, the two of them done such an amazing job in such a short time. It's very impressive.
Yes. So thank you all, and everybody stay safe.
Thank you very much.